Okay, so recording in progress, as the system has told me. Um, now, I'm going to share with you the screen. So that will be, so again, I'm going to start with the cardiac questions. So the sets of questions that we didn't have the time to cover in class was the acute coronary syndrome, ACS, patients with angina and civil angina, acute MI, all these questions, the questions will cover all the three content areas. And let's start with, so briefly, I would just go very quick. We went over this content already, right? And these questions, the embedded ones, but we have a good number of questions towards the end of the PowerPoint slides that we didn't have the time to do it, or answer them. So the enzymes, we'll go over the concepts and as we answer the questions. And most of these techniques, so I don't want everyone to fret about these kind of procedures or advanced interventions like cardiac interventions, because these are the advanced techniques that we will cover in Adult 3. So most of the cardiac PCI, which is coronary or cardiac interventions, will be covered in Adult 3, including the laser technology, the balloon angioplasty, the CABG, and other techniques that will be covered in Adult 3. So I'm just, I included the slides just to show you the different types of cardiac interventions that you will be cover in next semester in the fall. All right, so let's start with the first question. And please take turns. I'm not going to, call names or, just, whoever ready is just starts reading, please. Number one.
Which patient is most likely to be in the fibrous stage of development of coronary artery disease?
So this question is about the atherosclerosis and the atheroma, or what is called the plaque deposits in the coronary arteries, and that's when the patients start to experience the chest pain from the angina, and that may develop that progress down to become like a blockage, 70% or up to even 100% blockage of the coronary arteries that result in a severe angina or acute MI. With the blood clot has formed and included most, all the artery, that results in acute MI. So so it's about the stages of development of the atheroma. When it's like mature atheroma, it's complete atheroma, because that takes like years in terms of patients will be on certain diet, when they oils or like fats and all that stuff that will increase the thickness of the atheroma and the deposit and the artery, and eventually is to the blockage. So the answer is
C.
C, right? So the 32 years thickened coronary artery or arterial walls with narrowed vessel lumen. So it's all about the lumen that becomes occluded almost. Again, some patients would live with severe angina, still angina, it's not acute MI, but they, for years, they will live with this 100% blockage, complete blockage of one or two vessels, which is coronary arteries here, and they survive, but they will have like angina, so severe chest pain when they walk, when they exercise, when they do any activity. But what makes them the heart or that specific area being occluded or deprived from the perfusion is that they have a good collateral circulation. If you recall the collateral circulation, the heart and the brain, right? So I think we talk about this concept. So it's all about the blockage and the narrowing of the vessel. Okay, good. Number two.
What statement accurately describes the pathophysiology of B? It's B. The endothelial changes are caused by chemical irritants such as hypolipidemia and
yes, hypolipidemia. Yep. Very good. We just had met Cindy and Ashley and Carlin. Okay, sorry. All right. So I'm sorry. Yeah. So B, the etiology of CAD or coronary artery disease includes atherosclerosis as the major etiological or etiology or cause. So the pathophysiology of the development of the atherosclerosis and resultant atheroma or plaque deposit, resultant injury and inflammation, an infection causing the local inflammatory response. So that will eventually allow for more blood clots to form on the vessel. Number 3.
Which patient does the nurse identify as having the greatest risk for a CAD?
So look up the risk factors that may predispose patient or have to contribute more, contribute to the development of the CAD. Risk factors. The one that has.
I think A.
So if you okay, A is age.
Diet.
If you go between A and B, look up A and B. You have 54, and remember that that's 75 years old. Also, there is the age, another risk factor, right, from arteriosclerosis.
Mm-hmm.
So we have, and remember also we have modifiable and unmodifiable. If you go back just to pathophysiology and do some review, you find that we have modifiable and unmodifiable risk factors. When you talk about age or gender, or so the white woman has one unmodifiable risk factor, which is age, right?
Mm-hmm.
And 2 modifiable factors, risk factors, which include the hypertension and physical inactivity. So you can combine all of the the 3 factors compared to others, A, C, or D. Sorry, yeah, A, C, or D. They don't have 3 factors. So either smoking or gender or what else, like, or have like history of disease like cardiac disease. So the one that has the more than 2 risk factors or 3 risk factors is B. Right. So B is a correct answer. Number 4.
What would the nurse emphasize when teaching women about the risk and incidence of CAD? And it would be D, that CAD is the leading cause of death in women with a higher mortality rate after myocardial infarction.
Right. Yeah. Yeah. So the coronary artery disease is the leading cause of death in women. And women have also had much higher mortality rate within 1 year following the acute MI, after the acute MI, than do compared to their counterpart or compared to men. So the smoking carries specific problems for women because smoking has been linked to decreased natural estrogen levels and early menopause. Now, classic manifestations, the usual or classic manifestations of acute MI, very small percentage of women than men, they will be presented with the classic manifestations of coronary artery disease and acute MI as well. And it's from evidence, or maybe I would say research, they found that women also delay the seeking care longer than men. The estrogen, the hormone estrogen replacement, and I think we talk about this at some point in class about the HWI, about the human, the hormone replacement therapy and the Women's Health Initiative, and the impact of these hormones on the women's health and the nationwide research that has been done along longitudinal research, and they found that estrogen and progesterone and how these hormones resulted in acute cardiac disease and sometimes was death and fatal consequences or death of women who had received these hormone replacement therapy for a while. So that's why you will never now see. It's very. I mean, we still have this people are prescribing the hormones, but any case scenario it's not for everyone. It's not good for every single woman. Most to prevent or to treat the hormones for all of them postmenopausal. It's now we see very individualized kind of plan, and not for all. It used to be like all postmenopausal should be on these hormones, but after that, Women's Health Initiative and the research which have found that these kind of complications, they completely stop that the hormone prescription, which is DHR, hormone replacement therapy, HRT. So yeah, D. Now we'll go to number 5.
Which characteristics are associated with LDL? So that's all that applies.
So this is the bad, right? This is not good. That's the poor, bad cholesterol. So it contains more cholesterol than other lipoproteins, and it have the attraction or affinity for the arterial walls. So it kind of stick to these walls more than any other lipoprotein or cholesterol, and correlate more closely with increased incidence of, it's like contribute to the atherosclerosis and coronary artery disease. So we can, with this description, we can go with B, right?
Yes. F.
C. Yeah, the LDL, it has more attraction, more affinity for arterial walls, and more correlate, to the CAD and atherosclerosis. So B, C, and actually E is the question I have here. E, which is high levels, correlate most closely to the coronary artery disease, and then I have here the higher the level, the lower the risk for CAD. So this F is incorrect, right? So that's not true. And then E, high levels correlate closely with, yeah, it contributes to the coronary artery atherosclerosis and CAD. So E is correct as well. So D carries lipids away from arteries. Which one that carries the lipids away from the arteries to the liver?
HDL.
It's the HDL, the good cholesterol, right? The good lipoprotein. So contains more cholesterol, that's correct. Has affinity to and more attraction for the arterial walls, another one. So B and C. And then we have one more, right? Which is E. So B, C, and E. Number 6.
Which serum level elevation along with LDL is strongly associated with CD total? I would say the total
The
serum.
fasting, yeah, the fasting actually, that's the one. Yeah, the high fasting triglyceride blood levels, they can they contribute to the or associated with the cardiovascular disease and diabetes as well. So both cardiovascular and diabetes, because that has to do with the blood vessels. So the apolipoproteins are found in different amounts, like varying amounts on the HDL, and they have a different mechanism for the removal of the fat from the plasma, which is more protective. When you see apolipoprotein, it's had more of the protective mechanism for the blood vessels, as it removes the fat from the plasma. Number 7.
The nurse reviews the following laboratory results for 4 patients. Which patient would the nurse identify as having the greatest risk for CAD, and teach first about prevention?
Yeah, so if you apply the numbers in terms of the ranges and values for all the different types of cholesterol, LDL, HDL, VLDL, total cholesterol, and the numbers that we shared or like in discussing class, which one do you think has the highest or the greatest risk for CAD?
D.
D, right? D. So among all these results, the option D right. So 250 cholesterol, triglyceride 164, LDL 172, and then the HDL is 32, very low HDL. And all the other numbers are also pretty high, but the one that is striking, that is most contribute also, is the low HDL. All right, and number 8.
The nurse is encouraging a sanitary patient with a major risk of CAD to perform physical exercise on a regular basis. In addition to decreasing the risk factor of physical inactivity, the nurse tells the patient that exercise will directly contribute to reducing risk factors. B.
Right. Why B?
Because I think those are like the modifiable risk factors. So yeah.
So yeah, the increased exercise and activity without an increase in caloric intake will result in losing weight. So weight loss will result from that, reducing the risk associated with obesity. So the exercise would increase the lipid metabolism and increases the good cholesterol, the HDL. Thus, therefore, that will reduce the coronary artery disease risk. The exercise also may indirectly reduce the risk for coronary artery disease, because it will control the blood pressure. That if the patient is hypertensive, that will be controlled. It will control the blood pressure. It will promote the glucose metabolism, because it has an effect on the insulin, sensitivity to insulin. And patients, if they are diabetic, right? So if they are hypertensive, they are diabetic, they will control blood pressure. Diabetic will control their glucose metabolism, and also as it will reduce stress as well. So combining all these positive aspects or outcomes from exercise, that's why it's the answer is B. Number 9.
During a routine health examination, a 48-year-old patient is found to have a total cholesterol level of 224 and an LDL level of 140. What diet changes would the nurse teach the patient to make? Select all that apply. Abstain from alcohol use.
So 224 cholesterol and 140 LDL. So therapeutic lifestyle changes or modifications, in the therapeutic lifestyle management or changes that will lead to reduction in saturated fat and cholesterol intake, these type of changes that we expect, right? So the whole milk products, for example, red meat, eggs, as well as the butter and margarines, lard, and solid shortening should be reduced or eliminated from the diet. So if triglyceride levels are high, alcohol and simple sugars should be also reduced. So we can go with A, the free fat milk, C, reduce red meat in the diet, and then E, avoid foods prepared with egg yolk. All right, number 10.
Professor, you say it's A, C, and E?
Yeah, A, C, and E.
Okay.
Okay.
The nurse will teach which patient to make diet change to reduce the risk of CAD.
Changes to reduce the risk of CAD.
B.
So, right. So the
Okay.
therapeutic lifestyle changes, sorry, those with 2 or more risk factors for CAD. And then we have D, cholesterol over 200. B, all patients to reduce CAD risk.
Yes.
So, right. So the therapeutic lifestyle changes that includes recommendations for all people, not just those with risk factors. So we can decrease the risk for the cardiac events and coronary artery disease. Right. So 11.
A
60-year-old
62-year-old woman smokes a pack of cigarettes per day and has a BP of 138/88. She has no symptoms of CAD, but the recent LDL level was 154. Based on these findings, which treatment plan would the nurse expect to be used first? Diet therapy and smoking cessation.
Right. So with the diet therapy and smoking cessation are indicated for this patient without coronary artery disease who has pre-hypertension. So according to the numbers, the blood pressure, systolic, diastolic, we can tell that this is a pre-hypertension, and the LDL is either equal or higher than 130. So when the patient's LDL is 75 up to 189, with a 10-year risk for CAD, the medications or drug therapy would be added to diet therapy. So that's a different class of patients. So may require that we have to add a medication to the diet therapy, which is that when the patient LDL level is between like 75 and 189 with a 10-year risk for coronary artery disease or cardiovascular disease of 7.5% or above, then that CVD, the CVD, we didn't go over the numbers and percentages of the risk for coronary vascular disease or cardiovascular disease, but the when it's over than or higher than 7.5%, that's a high risk. Then or needs at least requires that we have to add also a medication like statin or other medications to lower the lipids and cholesterol. But for this one, or for this patient, it's pre-hypertension and LDL is 154. So it's still within the range that it can be done or worked out, managed with the lifestyle management and diet. So lifestyle changes and diet. So diet therapy and smoking cessation should suffice. Okay, 12.
What are manifestations of acute coronary syndrome? Select all that apply.
C, D, and
Yes, go ahead. C, D, and E. Remember we said that the angina, that the stable angina is not usually listed under the ACS. The unstable angina, right? Unstable angina, and then STEMI and the non-STEMI.
Mhm.
Right? These are the two or three. I mean, you can, because acute MI is either STEMI or non-STEMI. So unstable angina and acute MI. So C, D, and E. Good. 13.
Myocardial ischemia occur because of increased oxygen demand and decreased oxygen supply. What factors and disorder result in increased oxygen demand? B.
So increased oxygen demand is caused by increasing the workload of the heart. So when the heart is trying to work overworked or to work faster and to work harder to maintain the high demand for oxygen for perfusion, including the left ventricular hypertrophy and with hypertension. So the increased oxygen demand would include left ventricular hypertrophy when the left ventricle becomes the thickness and the ventricle becomes larger, and then with hypertension, patient like a long-standing, in other words, that the long-standing hypertension leads to cardiomyopathy and hypertrophy of the left ventricle. Sympathetic nervous stimulation, the SNS, sympathetic nervous stimulation with the tachycardia, increased heart rate, and anything that precipitate or lead to the angina, in which that requires the heart to work faster. So increased cardiac workload with aortic stenosis, that requires that the heart will work faster because there is a stenosed valve. D, angina in the patient with atherosclerotic coronary arteries, same concept. E, left ventricular hypertrophy caused by the chronic hypertension. Patients with long-standing hypertension, they tend to, develop this problem, especially uncontrolled, undiagnosed, undertreated hypertension. They tend to develop that. So with good management, rarely you would see this condition or this complication. So B, D, E, and then the last one, which is the sympathetic nervous system stimulation by medications, by emotions, excretion. Now, the drugs, just one example of the drugs that may stimulate the sympathetic nervous system to a level that sometimes you would admit the patient or taking care of the patient in the emergency department as if they have an acute MI. Cocaine abuse, cocaine like overdose or toxicity from cocaine, patient will be presented with exact symptoms as if they have acute MI until you will find out to rule out the acute MI from the cardiac enzymes. They will have extremely high blood pressure. They will have tachycardia, palpitations, sweating, and all the symptoms very kind of typical and similar to the acute coronary syndrome, acute MI. And that's an example of how the drugs sometimes not really, and there are other drugs that may increase that would have an increased to increase the heart rate, like atropine. It will increase the heart rate because it's CNS. It's anticholinergic, but also increase the heart rate. So 14.
What causes the pain that occurs with myocardial ischemia? Is this one? A? No, is this C, lactic acid accumulation during anaerobic metabolism?
Yes, exactly. So when the coronary arteries are occluded, there's occlusion in the coronary arteries, the arteries that which perfuses the myocardium. So when there's a occlusion in these arteries, the contractility, it will stop or cease and stop after several minutes, depriving the myocardial the cardiac cells and tissues of oxygen and glucose for aerobic metabolism. So then the anaerobic metabolism will start or begin, and that will lead to the accumulation of the lactic acid. So when the patients develop or experience this chest pain from the acute MI, usually it's from two things: the accumulation of the lactic acid, because cells are having this metabolism with the absence of oxygen, anaerobic metabolism. So we have lactic acid accumulation, and we have ischemia. So the type of pain the patient would have with the acute MI, it's ischemic pain, and also from the lactic acid accumulation, which will irritate the myocardial nerve. Then it will transmit the pain. Like the message would go to the cardiac nerves and to the upper posterior root and the central nervous system. But the major concept here is that, and for question number 14, is that the coronary arteries occluded. There is decreased perfusion. There is an aerobic metabolism that would take place now with the accumulation of lactic acid, plus there is an ischemic changes in terms of this decreased perfusion and ischemia. So the type of pain is called ischemic pain in acute MI. Number 15.
What types of angina can occur in the patient who does not have CAD? Select all that apply.
And I think I mentioned in class that I have seen a few cases, patients who are super healthy, never have any cardiac events, no cardiac issues, never been diagnosed with any cardiac problem, not even hypertension. Their blood pressure within range, everything they are super healthy, and they are and then all of a sudden they will have like 2 or 3 vessel 100% blockage, complete blockage, and then they will have syncope, and then will go to the cardiac cath and undergo the procedure. They will find their patient has a 2 or 3 vessel occlusion, and that's kind of the type of patients who does not have a coronary artery disease. So an example of that would be the spasm, like in Prince middle angina, C, right? So angina and the microvascular angina. They may occur in the absence of coronary artery disease. So Prince middle angina, for example, it's from the spasm of the coronary arteries. It's not because of the atheroma or because of the microvascular disease. That's from the coronary microcirculation. The silent ischemia. So the answer is C and D, but the silent ischemia, it's more prevalent in patients with diabetes, and it contributes to asymptomatic myocardial ischemia. And we talk about nocturnal. It's usually occurs at night, and the chronic stable angina, we refer to the chest pain that occurs when the patient has a new onset of duration, intensity. It's the same. Sorry, that's the same like a stable angina, right? Stable angina. That's when the patient anticipates the angina with the activity. So it's the same onset, same pattern, same intensity over a long period of time. And I have seen patients also who will live with this stable angina and refusing the CABG and open heart surgeries. So they will just live on, with on nitroglycerin, and they will just tolerate the chest pain with all types of activities, and they will, survive. But some of them will get have an heart attack. Others experience either cardiac complications or acute MI. So that's for number 15. Number 16.
Wait, 16 you said?
No.
17? What'd you
We
say,
are doing
Professor?
16. Yeah, 16, yeah. Because we just did 15.
Yeah. Which characteristics describe unstable angina? Select all that apply.
So unstable, right? So the stable, I remember I just described stable. So what about the unstable angina?
It would be B and D.
D, exactly. Right. Mm-hmm. Yeah.
Characterize an increase.
Yeah. B and D, yes.
Okay.
17.
Tachycardia that is a response of the sympathetic nervous system to the pain of ischemia is detrimental because it increases oxygen demand and
So the increase in the heart rate will decrease the time for the heart to spend in diastole. Remember that we said that the heart, the entire body gets the perfusion when the heart, right, pumps the blood to the systemic circulation.
so it's
That's
D.
when every single cell, right? Well, that's when every single cell of our body gets the perfusion from the heart. The heart will benefit from its own, right, pumping when, not when they pump the blood, when the systole.
What is
That's
the
what during the diastole, right? During the diastole, that's when the blood gets into the coronary arteries. So the heart, in other words, that you can say that the heart perfuses its own cells or its own, like, myocardium during the diastole, not during systole. Systole is good for the rest of the body. The heart benefit from the perfusion for its own blood, right? During the diastole, not systole. So the faster the heart beats, the less it gets blood, right, perfused to the myocardium. So the increased heart rate decreases the time the heart will spend in diastole, because the diastolic time will get short, so become short, and then that will reduce the perfusion or blood flow to the myocardium. So the answer, right, is D, impairs perfusion of the coronary arteries. All right, 19. 17,
18.
Yeah, we are done with 18, right?
We just did 17.
Oh, I'm sorry.
did
Yeah,
17,
17.
yeah.
Sorry, 18. Yeah. 18, right.
Which effects contribute to making nitrates the first line therapy for the treatment of angina? Select all that apply. So then it would be A, decrease the preload.
Nitrates, yeah, it's very important drug medication to review for cardiac and for angina, for patients with chronic or any type of angina, stable or unstable. So nitrates are a very important drug. So A, decrease preload.
And also B.
And also it will decrease the preload.
Afterload.
Will decrease both. Preload and afterload, right? Yeah, preload and afterload. Preload, this is amount of blood before the systole, and the afterload, which is the resistance within the systemic circulation blood vessels, right? So, yeah, decrease preload, it will decrease afterload.
And we'd be dilating
then dilate coronary arteries. Yes, that's definitely the main function of nitrates, is that it will dilate coronary arteries, and eventually with that dilatation that leads to the decrease in preload and afterload. And 19. Others to contribute, please participate. Other people.
The patient who has used sublingual nitroglycerin and long-acting nitrate now has an ejection fraction of 38% and is considered at high risk for a cardiac event. Which medication would be added first to vasodilate and reduce ventricular remodeling? I'm gonna say correct.
The captopril, the ACE inhibitors, right? So would be added. So the ACE inhibitors so it's a vasodilator, and it will decrease the endothelial dysfunction and may prevent the ventricular remodeling. The Plavix, we know that clopidogrel, which is Plavix, right? It's an antiplatelet agent, and it's usually used as an alternative for the patients who are not a good candidate for the aspirin. When we can't use aspirin, we can replace it with clopidogrel. Then now what is diltiazem? Cardizem. Diltiazem is a
CCB?
CCB, right? It's a CCB, so it would be used to decrease the vasospasms. Always good for vasospasms because that's a calcium channel blocker. So it's good for the vasospasm, but it's not known to prevent any ventricular remodeling. And then the metoprolol, which is a beta blocker that is usually inhibits the sympathetic nervous system of the heart. 20.
When teaching a patient with angina about sublingual nitroglycerin tablets, what should the nurse include? A, lie or sit and place one tablet under the tongue when chest pain occurs.
And how many times that patient can repeat this same procedure? Action or tablet to taken like under the tongue. How many times they can repeat this?
3 times.
Within how long? The time frame?
Yes.
And after that, they have to call 911.
3 times.
3 times every 10.
Every
Right,
5
yeah.
minutes.
That was 5
Right.
minutes.
Up to 3
5
doses,
minutes?
5 minutes apart. Yes, 5 minutes apart. 3 times, like 15 minutes total. So after 15 minutes, with 3 tablets taken, no resolution, or there's the pain doesn't subside, then that's when it's time to call
911.
an EMS. Right, exactly. If the systems persist and patients still have the same symptoms or chest pain after taking the 3rd one, so that's critical. That we these are the teachings that we will share with or provide with our patients. 21.
I'm sorry, Professor, what was 19?
Yeah, 19 is captopril, the ACE inhibitor.
Okay, thank you.
Yeah, 21.
The nurse is teaching an older adult with CAD about the treatment for angina. What instruction would the nurse include? Also, I'll say A because
Orthostatic hypotension, it can cause dizziness and fall, right, in older adults. Patients on anti-anginal medications or drugs that decrease preload. When the preload decreases, which is the blood prior to or right before the ejection from the left ventricle, that's when patients develop that kind of change in reflex and decreased perfusion to the brain, and that will result in a orthostatic hypotension. The 22.
Why must unstable angina be identified and rapidly treated? Is it D?
The spasm. The spasm is remember we said that the transmittal angina, that's the spasm.
Yeah.
So any type of angina that is associated with severe pain, the EKG or ECG changes or dysrhythmias, that's for C. Then for the basis of the spasm, that's transmittal angina, and usually that's pretty much I would say the characteristic of this specific type of angina, the coronary artery spasm. That's for D. Now C, rupture or unstable plaque may cause complete thrombosis of the vessel lumen. So the unstable angina is associated with the rupture of one stable atherosclerotic plaque that would expose the inner lining or the intima of the blood, of the blood vessel to the blood, and stimulate the platelet aggregation and local vasoconstriction, and that will lead to the formation of the atheroma. So it's kind of exposing the blood vessel to the atheroma or plaque to be formed. So C, right? So C, which is a rupture or of the unstable plaque, may cause the complete thrombosis. Patients with unstable Yeah, patients with unstable angina, they need immediate hospitalization and monitoring because the lesion is at risk, increased risk of complete thrombosis with the progression to become acute MI. So C is the correct answer. 23.
A patient is reporting chest pain. What would cause the nurse to suspect the patient is experiencing stable angina rather than a myocardial infarction? A, the pain is relieved by NTG.
Yeah, you're right, exactly, which is one of the primary differences between the pain of angina and pain of acute MI. The angina or anginal pain is usually relieved by rest or nitroglycerin sublingual, right? So which reduces the oxygen demand of the heart. The acute MI, it doesn't. It's a whole different scenario. So that's why when the patient doesn't get resolved. I mean, the relief of chest pain relief after the third sublingual, either tablet or nowadays we will find it also nitroglycerin as spray, right? Equivalent to the sublingual tablet. So then after the third tablet, 15 minutes, later, then pain persists, then the patient's supposed to call for EMS or 911. All right, 24.
A patient admitted to the hospital for evaluation of chest pain has normal serum cardiac biomarkers 4 hours after the onset of pain. What non-invasive diagnostic test can be used to differentiate angina from other types of chest pain? B.
The exercise stress test. Yeah, it will reveal any changes in the EKG that indicate the impaired coronary circulation when the oxygen demand of the heart is increased. So we would know that when the patient goes on the treadmill and they start running or that treadmill. So the exercise stress test very telling about this specific indication. So the EKG, just one shot of EKG or ECG, is not conclusive for coronary artery disease, and negative findings do not even rule out coronary artery disease. So the angiography can detect the narrowing. If you want to look at just for the narrowing of the coronary arteries, you will do the coronary angiography in the cardiac cath or or cardiac cath, or you can do that's a whole different procedure. But the angiography, it will just provide you with evidence that there is some arteries are stenosed or occluded. Now the echocardiogram, we have three, we have different types of echo techniques, echocardiogram of various types, and we identify the changes, abnormalities in the heart, like valve problems, stenosis, regurgitation, enlargement of the left ventricle, the thickness of the wall of the ventricles and atria. So these type of things that would exclude, you would expect from the echocardiogram. But the exercise stress test, that's the correct answer. 25.
A 52-year-old man is in emergency department reporting severe chest pain. Which assessment finding leads the nurse to believe the patient is experiencing a myocardial infarction? D. There's no relief at rest or position change.
Yes, exactly. Yeah. We have to go a little faster maybe with answers because we have also another set of questions for the ophthalmic. All right. So because I just, some of the concepts I already explained, right? Like for example, 25, I already went over this few times, right? The same concept. So let's just go to 26.
At what point in the healing process of the myocardium following an infarct does early scar tissue result in an unstable heart wall?
Like by for example, 4 to 10 days, the necrosis or necrotic tissue, will be cleared and the collagen matrix for scar tissue has been deposited. So that would be like 4 to 10 days. Here, you're talking about the myocardium following the infarct does yearly scar tissue result in an unstable heart wall that will be 10 to 14 days after the acute MI. So 10 to 14 days, like 2 weeks after the acute MI, if your scar tissue is weak and is vulnerable to increased stress because of the unstable state of healing at this point, as well as the increasing physical activity on the patient. So 10 to 14 days, so it's like 2 weeks after the acute MI, that's when we expect these changes or the healing process of the myocardial infarction take place. 27.
What would the nurse do to detect and treat the most common complication of MI? Use continuous cardiac monitoring.
Right. So the most common complication of acute MI is the changes in the cardiac conduction system, which is, in other words, will be presented as dysrhythmias, and the continuous cardiac monitoring will allow us to identify and treat any type of dysrhythmia that may result or cause, so we can prevent further complications and deterioration of the myocardium and or sudden death, sudden cardiac death. So that kind of alert us to the changes in the dysrhythmias. We can treat it. We can identify dysrhythmias and treat them as they appear. 28.
While assessing the patient who had a MI, the nurse auscultates crackles in the lungs and an S3 heart sound and S3 heart sounds. Which complication should the nurse suspect? Maybe B, heart failure due to the fluid buildup.
Yes. So the left-sided heart failure, which can augmented or escalate to become cardiac shock, because the previous, if you remember the previous, okay, the previous question, like if you go to 27, one of the options was crackles, dyspnea, and crackles, right? So auscultation of auscultate the lungs for crackles, for example. So the crackles, dyspnea, and tachypnea or tachycardia, they indicate or may indicate the heart failure, for example. And was another one, the hourly urine output. When would you measure the hourly urine output? Measurement of hourly urine output and vital signs, like indicates to detect what kind of things you are going to indicate or to detect. Symptoms of what? Like symptoms of, like one of the complications post-acute MI, expected complication post-acute MI, and when you measure, when would you measure the urine output? So you would
hypovolemic shock.
Detect. It's not hypovolemic, by the way. It is shock, but here it is a type of shock, but it's because it's cardiogenic shock. Yes.
Okay.
So always, so that would be an answer for the detection of the acute, the cardiogenic shock status post-acute MI. So question number 28, that's correct. B is correct answer, heart failure. So left CHF or left heart failure, which can escalate the to a complication called cardiogenic shock. So initially, the patient will be presented with manifestations like mild dyspnea, restlessness, with the pulmonary congestion, crackles, may become maybe agitated, apprehensive. You will hear also some S3 and S4 heart sounds. And we know the right side heart failure, all these manifestations that are always contribute to the respirations, like, coughing, the respiratory problems and so forth. So the I'm sorry. The right heart failure has to do with the edema, right? The edema and lower extremities edema, hepatomegaly, and other stuff. Okay, number and GVD and okay, number 29.
In a patient who reports chest pain, which result can distinguish a stable angina from myocardial infarction?
So unstable angina and acute MI. What distinguishes between these two, the distinctive confirmatory diagnostic test or element that will distinguish between or distinctive, lab work to say this is angina and it's not acute MI. Even unstable angina is different from the acute MI, right? So what type of test may distinguish between these two? Specific about the acute MI, what will be the first thing you would do in the ER? The first test to rule out the acute MI in the ED, the emergency department.
The CKMB.
Cardiac enzymes. CKMB is not specific like troponin. CKMB, remember that we provided a clear, distinction between and differentiation between the troponin and the two different types of troponins, I and T, and then difference between troponin and the CKMB, difference between troponin and the myoglobin. And we said the most determinant, the one that can, that is linked to the heart, and that's specific about the heart, is very sensitive and specific test for the myocardial activity or injury. So the cardiac specific troponin, T or I, they have they are very sensitive, they are very specific for the myocardial injury than any other enzyme, including the CKMB or myoglobin. We don't usually go with these, so to rule out the acute MI in the ED, definitely you will go right to the troponin. See what's the when we say cardiac enzyme, we know the policies, for all hospitals, they use troponin as the most determinant and the most reliable enzymes to detect any changes or injuries in the heart, including the acute MI. So C is the correct answer. 30.
A second 12-lead ECG performed on a patient 4 hours after the onset of chest pain reveals ST segment elevation. What does this finding indicate?
So ST segment elevation, remember we said ST elevation? It's C, right? So MI associated with prolonged and complete coronary thrombosis, acute MI, right? 31.
What phrase describes transmyocardial laser revascularization, TMR? C, laser created channels in the heart muscle to allow blood flow.
Yes, revascularization. And again, this is one of the advanced, I think, techniques or interventions, cardiac interventions that will be covered in adult Hill 3. 32.
Which treatment is used first for the patient with a confirmed MI to open the blocked artery within 90 minutes of arrival to a healthcare facility?
Yeah, just to clarify about the TMR, which is the transmyocardial laser revascularization. It's a treatment, it's a cardiac intervention or treatment used for patients who are not a good candidate for eligible or like inoperable, not good candidate for acute for CAD, or patients with acute MI, and they are not good candidates for, like, let's say, an open heart or that. So they will do the TMR. They use a high energy laser to create channels in the heart to allow for blood flow to the ischemic areas. That can be done using the left anterior thoracotomy incision. So they have like incisions different than cabbage, and sometimes they do cabbage surgery to do this technique. So a stent is different, and we will go over stents also in adult L3. So question number 32, it's cabbage. So the again, if doesn't make sense right now, but we will cover all these interventions next fall. All of them, all the cardiac, all the PCI. It's called PCI, percutaneous coronary interventions, including the angioplasty, including the laser technology, rotablators, and others. So the answer for 32 would be D, PCI, because the PCI is like a broad term, including or under this PCI, we have too many of the interventions. One of them is the angioplasty. 33.
In planning care for a patient who has just returned to the unit following a PCI, which activity can the nurse delegate to the assistive personnel? Check vital signs and any changes in heart rate, blood pressure, and pulse ox.
Right. So and again, also this one, another PCI or intervention requires that the patient will be coming from the cardiac cath or the incision in the groin done. So I'm not expecting that you would know all of this information, but keep it for next semester. 34.
Patient scheduled to have CABG surgery. How would the nurse explain the procedure?
Yeah, the cabbage, also another advanced question here, is that the cabbage, they usually, when they graft, to bypass the blockage from the aorta to, like, bypassing the blockage, they will have one or more than one graft within the cabbage surgery. So they suture like the graft between, from the aorta to bypass the blockage, and they use two different types of blood vessels. Either they will harvest it from the saphenous vein, from the lower extremity, the saphenous vein, it's long vein, or from the chest, that's IMA, intramammary artery. So there's pros and cons, like it's like each one, the vessel or the artery. We will talk more in depth about this in adult L3 and all of these details about the difference between the IMA and the saphenous vein. But that's in which these are the two different types of grafts or types of vessels will be used in these type of grafts in the cabbage surgery. So the answer is C. And 35.
What initial treatment would the nurse expect when caring for a patient with an NSTEMI? C, acute intensive drug therapy.
Right, so C, right. And then 36.
Drug treatment with retavase for a patient with a STEMI. Which finding would most concern the nurse? C, decrease in the responsiveness of the patient.
And because that indicates a complication, right? Or
yep, because the patient's not responding.
And so how would you provide like a rationale? And this is a good time to talk about rationales here. Is that when I asked if there is, under the questions that I request that you have to write a rationale, first of all, that you have to write just the rationale for the correct answer only. This correct answer is, here is C, right? So just put C, make sure that you put C, and then you will say, you provide me with a short, like very short statement, short, like Sometimes one word, few words, one sentence, whatever, but shouldn't be like, you know, too long. And then the second is that you don't have to provide a rationale for the incorrect answers, only for the correct answer. C, correct answer. Okay, why? Now, the decrease in responsiveness of the client or the patient. What's your rationale now that C is the correct answer here?
Hypoxemia. Okay.
So this is a good time to talk about the, you know, rationale, because I will find out that you came up, you know, with the correct answer, but it sounds like you don't have the exact rationale, right? That which have led to that, you know, you have answered the question.
Well,
So
only
I would like
because
to
he
hear
makes
from
the
you
most.
now. It's a time good that I hear from you now, saying that change of mental status or change of level of consciousness may reflect patient on ritablase. It's a TPA, right? And it's a thrombolytic medication. Patient would be at risk for
Bleeding?
bleeding.
Okay.
So this change of mental status or level of consciousness may reflect hypoxemia, but which had resulted from the internal bleeding. So patient has an internal bleeding, which is always risk with thrombolytic therapy. So that's would be your rationale, is that the decreased level of consciousness may reflect hypoxemia resulting from the internal bleeding. So the word bleeding, if you just put bleed, so for me, for you, so would say C, just put bleeding. I'm good with that. At least I understand that you selected C because you know that the bleeding is you know that have is a you know this factor, and the complication that may result from using this drug. So just only provide the correct answer, or like, you know, the number, like, you know, the C or D or A, and then you just provide your short explanation why this is a correct answer. 37.
The nurse evaluates the thrombolytic therapy for the treatment of an MI has not been successful based on which manifestations. Continues to have chest pain. That means it's not working.
Right. So if chest pain continues and resolved or doesn't subside, then I mean persists. So it's a sign that the reperfusion was unsuccessful. Okay, and 38.
The patient diagnosed with an MI is experiencing chest pain that is not relieved with IV nitroglycerin. Which medication would the nurse expect to be used next as CCB?
So experiencing chest pain that is not relieved with nitroglycerin, the IV nitroglycerin. So we have to take, you know, make sure that we understand this concept that the cardiac, that means the CCB, the ACE, CCB, and ACE inhibitors, they will not relieve chest pain related to acute MI. So CCB and ACE inhibitors, they will not relieve the chest pain related to acute MI. You will find that the IV, so I would like everyone to go and do some review about the morphine, the IV morphine sulfate, and its cardiac effect, the cardiac effect or benefit from IV morphine sulfate in patients with acute MI. You will find that the morphine sulfate, it decreases anxiety, first of all. Second, it will decrease cardiac workload because it's a vasodilator too. So the IV morphine sulfate as a vasodilator will decrease the anxiety, decrease first of all, anxiety, and then because it's a vasodilator, it will decrease the cardiac workload and decrease the preload because it's going to decrease the myocardial oxygen consumption. Once you decrease the workload, you will decrease the cardiac oxygen consumption, which relieves chest pain due to that, because it works on as a pain relief like medication, but also it has some cardiac benefits, and that will eventually patient will have a good relief of that chest pain from this IV morphine sulfate. So the answer should be A, and that's that's encouraged that you go talk, review about the morphine IV morphine sulfate and the acute MI. 39.
What is the rationale for giving Colace to a patient after an MI?
And this is one of the most important concepts also in CCU, like patients in the admitted with acute MI in the CCU cardiac units. Very important concept.
You don't want them to force it.
Defecate, right? Yeah, in the bathroom, because the Valsalva maneuver, right, that will increase blood pressure. So the docosahexaene, so patients will be on docosahexaene sodium stool softener, which will prevent straining, and that may provoke dysrhythmias. The Valsalva maneuver or straining in the bathroom can provoke dysrhythmias. So B, right? Okay. Okay, 40.
Patient who has hypertension just had an MI. Which of the medications would the nurse expect to administer with the goal of decreasing cardiac workload? Beta.
In other words, yeah. So beta blockers. In other words, that we need to decrease the workload, the cardiac workload. You need the medication that's going to be a negative inotropic medication, negative inotropic med. No dopamine, no dobutamine, no ACE inhibitors, no ARBs. So it will be negative inotropic medication. So it's the beta blockers. 41.
A patient with an MI exhibiting anxiety, which, while being taught about possible lifestyle changes, which patient statement indicates to the nurse that the anxiety is relieved? I'm going to take this recovery one step at a time.
Right, yeah. So, right, A, okay. 42. Okay, so 42, it's a priority lowest, right, to the highest, or from the highest, sorry, from the highest, like number one, the highest to the lowest priority. We're going to rank all the 3, 4, 5, 6, right? 7, 6. From the first to the sixth. So the first one will be apply oxygen per nasal cannula, D. The second, check for vital signs. The third one, obtain EKG, 12 lead EKG. And then after that, you assess the PQRST and medicate as needed. Then perform focus assessment of the chest. And the last one will be notify the provider. All right, 43.
Which statement indicates the patient experiencing anger as a psychological response to an acute MI?
Okay. So, so the anger about the acute MI, being diagnosed with acute MI, sometimes being directed at family medical regimen, patient like become like non-compliant with medical regimen, or at staff, or so stating that the chest pain is not a big deal is kind of patient still in a state of denial, right?
Yeah.
And so the answer is
A.
D.
I was gonna say D.
D, exactly, D. So relaying an inability to care for self relates to that patient's dependency. Now, questioning what will happen if there is another attack is expressing anxiety and fear. Now, the depression may be expressed related to changes in lifestyle. Now, being realistic or developing the acceptance, realistic acceptance, that will be indicated or shown or seen in with actively engaging in changing the modifiable risk factor. Patient is actively taking some actions to modify, attempt to change their modifiable risk factors. So the answer is D. 44.
Which activity would the nurse and patient identify as a moderate energy activity during rehabilitation after an MI? A, golfing.
Right. So it's a moderate energy activity that expends like 5 metabolic equivalent units, and it's within the 3 to 6 METs activity level desired for patients by the time of discharge from the hospital following the acute MI. So it is acceptable, right? 45.
A 58-year-old patient is in a cardiac rehabilitation program. Which sign or symptom would the nurse teach the patient is a reason to stop exercising? A, pain or
Right.
dyspnea.
Mm-hmm. Yes. 6. At what? 46, right?
What is the nurse's best approach when counseling the patient about sexual activity following an MI?
B.
B. Mm-hmm. Right. 47.
What advice about such, oh, sorry. Oh, yeah. What advice about sexual activity would the nurse give to a male patient who had an MI? Prophylactic nitroglycerin, maybe used.
Prophylactic, right. Mm-hmm. B. Yes. 48.
A patient is hospitalized after successful resuscitation of an episode of sudden cardiac death. During the care of the patient, what nursing intervention is most important?
Continuous ECG monitoring.
Continuous ECG. Mm-hmm. Yeah, because of the many patients who have sudden cardiac death experience the sudden cardiac death because of coronary artery disease that don't have an acute MI, but they do have dysrhythmias that can cause death. And that's similar to the case, the scenario that we mentioned earlier about patients who have never been diagnosed with any cardiac disease, but they will have a syncope and severe acute MI, even with no CAD diagnoses. So I'm going to, we have, what is that? 10, 20 minutes, right? So we have less than, I think we have a few questions here. Let's see if we can answer all of them. Okay, so some of the questions I will be just providing the answers very quick, given that we have 20 minutes to to answer all the how many questions. Okay. Let's start with first one. Am I sharing the screen with you or not?
Oh, yes, we can see it.
Yeah, you can see it? Okay.
Yeah. Would it be the vitreous humor?
Vitreous, yes. Okay, D. And then 2 functions of sclera, or 1 function of the sclera. It's protective outer layer of the eyeball. 3, yeah, some of the questions are patho or EMP and maybe patho. So especially the first few questions. The conjunctiva, what accurately describes the conjunctiva? It is the transparent mucous membrane lining the eyelids, right? So it's C. And the junction of the eyelid is the medial and lateral canthi. So the optic disc, when we talk about the optic disc, that's the, remember we said that, patients with glaucoma, sometimes that increased pressure may damage the optic disc. I'm making a little kind of cupping of the optic disc. So the optic disc, that's the point where the optic nerve leaves the eyeball. And that would be right here. And number 4, which tissue nourishes the ciliary body, iris, and part of the retina? And that should be the choroid, which is the middle one. See the retina, the inner lining, and then the middle one is the choroid right here, and then the outer one is the sclera. So these are the 3 lining: retina, choroid, sclera, from inner, middle, and out. So retina, choroid, sclera. So the answer for 4 is C, the choroid. It's like the blood vessels and nourishment and all of that for the iris and ciliary bodies. Number 5. So when obtaining a health history from a patient with cataract, it is most important for the nurse to ask about the use of which of the following drugs. So which drug is most concerning when it comes to cataract? That is drug that has been associated with the development of the cataract and glaucoma as well, and glaucoma.
Steroid?
Steroids, right? Steroids. Yes, steroids. Now, the use of hypoglycemic, for B, for example, oral hypoglycemic agents, it will alert the nurse to the presence of diabetes and the risk for what type of ophthalmic problem. It's not cataract and it's not glaucoma. These, diabetic patients or patients with diabetes on oral hypoglycemic agents, right? They may develop as a long-term complication from diabetes, they develop ophthalmic or eye problem. What specific, like, type of eye complication or eye problem as a long-term complication from diabetes patient may develop from diabetes?
Retinopathy.
Right, exactly. Diabetic retinopathy. The beta blockers may cause additive effect in patients with glaucoma. Because remember that the antihistamines and the decongestant drugs, they may cause eye dryness because of the antihistamines. They have like some similar characteristics like anticholinergic drugs and decongestants, because they kind of cause some dryness. So they will affect the eye also. They may cause eye dryness. So the cataract or glaucoma, the high risk for those who are on or patients on corticosteroids. Number 6.
The nurse document parallel following an assessment of a patient's eyes. What assessment findings support this statement? Constriction of the pupil when an object is brought closer to the eyes.
Right. All right, 7. Yeah, 7 is B. The fluorescein dye is used typically to identify corneal irregularities stain the bright green or application of the dye. So it's some type of diagnostic test. So it's different than the tonometer. Tonometer, remember that we said this is the device that we use to assess for the IOP, intraocular pressure, the pressure inside the eye. Number 8, the answer is C. So the patients, when they are diagnosed with hyperthyroidism, remember that part of the pathophysiological changes that patient will develop the bulging of the eyeballs and the kind of like protrusion of the eyeballs. It's the sign of what is called, the medical term is the exophthalmos, or another term. You can interchangeably use. Either you can say exophthalmos or ophthalmopathy or exophthalmos, both the same, which indicates that there is a protrusion of the eyeball and bulging of the eyeball as a sign of hyperthyroidism. Number 9. And the answer for this one is C. So the break in the retina anywhere in the eye is abnormal, and it indicates a potential loss of vision. So visual loss would be definitely resultant effect from any changes or any breaks in the retina. So number 10 is patient diagnosed with presbyopia. And yeah, we didn't go over actually myopia and hyperopia, or so presbyopia is it's an accommodation problem, and that will be lost with visual loss with aging. So the absence of lens is called aphakia. So the answer for 10 is D. Loss of accommodation with associated with age, that's presbyopia. And 11 is patient at the emergency department with a wood splinter embedded in the right eye. And the most appropriate intervention done by the nurse is to irrigate, remove the splinter, or cover the eye. So emergency management of foreign bodies in the eye includes stabilizing the foreign bodies or foreign object by covering and shielding the eye, with no attempt to treat the injury until the ophthalmologist can evaluate the injury. Even irrigation, sometimes it will be, they are performed as an emergency management. That would be just if there, for chemical exposure, right? Chemical agents or chemical exposure. And also pressure should never be applied because it will or could further the injury of the eye. 12, cataract. So patient is with early cataract tells the nurse that patient is afraid that cataract surgery may cause permanent visual damage. What do you tell the patient? The patient has this kind of significant concern about the cataract surgery. What do you tell the patient?
A.
So vision enhancement. So first of all, although cataract do become worse with time, surgical extraction is considered an elective procedure. So A is incorrect because of that. B, surgical extraction is generally safe, but infections can occur because it's a surgical procedure. The procedure itself is very simple, safe, but the post-op patient may develop infections. That's why B is incorrect. The patient also, so patient will still need glasses for near vision and for any residual refractive error of the implanted lens. And there are no proven measures to prevent cataract development or progression. So the answer is
D.
D, that the vision enhancement techniques may be used until the patient feels the need for cataract surgery. And if you recall that also in class, we discussed the different techniques and different lifestyle changes, like, the things that patient can benefit from, like assistive devices, and meanwhile waiting for the cataract surgery, right? 13, so D is the correct answer. D, vision enhancement. 13, in other words, what would you anticipate or expect as manifestations of cataract? Patients with cataract usually they are presented with the following. C, exactly. Yes. 14. Patient with bilateral, so both eyes are affected, not equally, but different extents of cataract. Scheduled for an extra capsular cataract. So it's a cataract surgery extraction with lens implantation. What would the nurse do pre-op?
Would it be A?
A.
Right. Yes. Yeah, the patch on the patch is usually removed within 24 hours. If used, within 24 hours will be removed, and the activities that are thought to increase the IOP, bending, coughing, lifting, they are frequently restricted post-operatively. Number 15, the answer is A and D, cryopexy, and the penetrating keratoplasty. So the cryopexy, which is the freezing of the retinal leaks or breaks in the retina, they do freezing and laser photocoagulation, in which that they create what's called the inflammatory reaction. These are procedures used with the scleral buckling to seal the retinal break. So A and D. 16. And this is a position that I mentioned in class, that's post-op. The patient must must position the head so that the bubble is intact with the retinal break, and may have to maintain this position for up to 16 hours a day for at least 5 days post-op. And this is specific about patients who undergo the pneumatic retinopexy, in which we use some type of gas injected in the eye. So the patient may go home within a few hours of surgery, or may remain in the hospital for several days. But the positioning is critical. So I will encourage that everyone to read it from the book, the exact positioning post retinopexy or any ophthalmic procedure in which that the gas will be implemented or used in these procedures. The position should be in which that the patient should have the head positioned so that the bubble is intact with the retina, and may have to maintain this position for up to 16 hours for at least 5 days post-op. And that's kind of, it's really difficult to kind of explain how is that position, but at least the affected side or affected eye will be positioned higher than the unaffected eye. And that will be the maintained for 16 hours up to for 5 days post-op. 17, the answer is so health promotion, nursing intervention for a middle-aged adult related to the glaucoma. So this is a good application question. Glaucoma, we know that glaucoma develops slowly and without symptoms. Patient is asymptomatic for the most part until they develop the closure angle glaucoma with the high IOP, right, higher than 50 pressure. Then that's when the patient starts to have the eye, like painful sensation in the eye. But other than that, the patient, for the most part, will be like the glaucoma is asymptomatic until you measure the IOP. You'll find it's elevated, and we said that the normal IOP ranges from the IOP pressure normal.
35.
I'm sorry.
25 to 35.
No. 30, when if the open angle goes higher than 32. So review about the IOP, the IOP, the pressures and the normal, the open angle, the closed angle, and it's critical because you can rule out and I diagnose patients with different types of glaucoma from the IOP pressures. And so the answer is C, because glaucoma develops, and as I said, slowly and without symptoms. So it's important that the IOP be evaluated every 2 to 4 hours in persons between age of 40 to 64, and every 1 to 2 years in patients. So I'm said 2 to 4. Sorry, every 2 to 4 years, and people who are like age between 40 and 64, and over 65 years old, we recommend that we do the IOP or the the pressure every 1 to 2 years. And then patients with family history of glaucoma, that more frequent measurement will be done in patients with a history of patients with family history of glaucoma. And 18, another question about glaucoma, diagnoses of glaucoma, and this is open angle glaucoma. And you will find that the primary open angle glaucoma is associated with gradual loss of peripheral vision, increased production of aqueous humor, the fluid in the eye, and the resistance to the aqueous outflow. There's like some type of a blockage within the eye and the meshwork. So the answer is A, D, and E. A, D, and sorry, A, D, and F. 19. The glaucoma and open angle closure. This one is angle closure glaucoma. So it's very similar to the previous question, but the 18, it's open angle, and 19 is angle closure, so closed angle. So 19 is a closed angle. So we'll look at the manifestations of angle closure. So angle closure will be manifested with or changes or pathophysiology, and manifestations will include A, lens blocking papillary opening. C, causes the loss of central vision and edema of the cornea, so corneal edema. E, sudden severe eye pain associated, because remember this one is open angle, patient did not have any pain, right, in the eye. Now here, ophthalmic pain with the angle closure, because the IOP extremely high, higher than 50. So A, C, E, and then F. Patient will be on hyperosmotic oral and IV fluids. And read about, it's really, critical that we go over the medications that will lower the IOP in the eye. Mainly, one of the main groups of meds are the anhydrase carbonic inhibitors. Anhydrase carbonic inhibitors, these meds will lower the IOP. And 20, I will provide the answer for the rest, maybe the rest of the questions. 21, I can go. 20, I'll provide, like I will post in Blackboard the answer for 20, and then 21, the answer is D, decreasing the ability to hear high-pitched sounds. So the rest of the questions from 21, it's all auditory. So it's the ear problems. So I will post the answers Blackboard for everyone, and stop sharing. And if you have any question, please.
No.
Okay, then I won't see you even the following, after the break with the exam 2. Professor Flood will be proctoring the exam. I won't be here, as you know, and I will see you in 2 weeks. My clinical group, I will still see you on Sunday. Don't forget about Sunday. I'll be here on Sunday in the lab, right? Sunday in the lab. Yeah, we won't, we'll be doing the simulation and validation. Sunday,
Professor McKee,
this coming Sunday. Yes.
I have a question, but can I ask it after class?
Okay, sure. All right, everyone, thank you very much. And have a great day and great break as well. Study
Thank
break.
you.
Thank you. Have a good one.
Take care.
you.
Thank you.
Professor McKee,
Yes.
I wanted to ask about my attendance since I wasn't present today. Would I be MAC absent?
1 second, Saratan, because I have to stop the